Good morning, friends, and Dr. Bhati, thank you very much for having me on your course. And what I'll be talking about is what is actually ectasia, how does it start, and how do we actually pick up these cases. Studies have shown that the incidence of ectatic disorders in patients is about 1 in 3,000. But there's a subset of study which also shows that in the pre-refractive surgery screening group, we find that the incidence goes up to 8%, which is a phenomenally high rate when we compare it to the previous studies. And why is it so? Because these patients have a frequent change in refractive power, they have a poor visual acuity quantitatively and qualitatively, and they have a dissatisfaction with glasses. Hence, they think getting a refractive surgery. So this subset of patients actually feel that refractive surgery is the eventual answer, and they end up to at these setups, and they wish that they can have this surgery done. Now, ectasia comes to our clinical settings in various formats. You see a case of keratoconus, a case of post-RK corneal ectasia, a case of post-LASIK thinning and ectasia. These are cases which come with very early subtle signs like Vogel's striae over here. You can see a Flescher's ring over here, and Terrien's marginal degeneration. You also have peripheral thinning disorders like you see pellucid marginal degeneration. And there are obvious signs, the case of keratoglobus in both eyes. Now look at this patient. She's a 24-year-old female, clinically normal looking eye, symmetric bow tie pattern on Placido corneal topography with a manifest refraction of minus 1.25 diopter spherical and minus 0.5 cylinder at 175 degree. Keratometry of 44.7 and 46.6. Apex, the corneal thickness was 500 microns with minimal corneal thickness being 494 microns. I think this is a very juicy proposition for hard-earned refractive surgeons. But actually, if you look at this patient, once we do a pentacam and we do the Bellin-Ambrosio enhanced ectasia display, you can see that there is a posterior element of posterior corneal ectasia over here on the posterior float. So hence, what we learned from this particular case is that it's not always apparent and obvious if you do anterior corneal surface analysis to screen patients for refractive surgery. Now let's first see the criteria and the qualitative criteria for diagnosing keratoconus on anterior surface analysis on Placido-based devices. You see egging of Myers like you see here. You see a localized increase in surface power with concentric areas of decreasing power, and there's a definite difference in the superior and the inferior area in the corneal power, which is known as the IS value or the inferior superior dioptric asymmetric value. Now, the quantitative criteria that are commonly used is central K more than 47.2, right eye versus left eye central corneal keratometry of more than one diopter difference, and average sim K of more than 45.7 diopters. One of the most pathognomonic signs on Placido devices to use and pick up these cases of corneal ectasia is SRAX pattern, or the skewed radial axis pattern. What it exactly is that if one of the hemimeridians, this is the one superior hemimeridian, this is the inferior hemimeridian. If there is a deviation of more than 30 degrees from the principal axis, this fits in the correct criteria of SRAX pattern, and these are pathognomonic of corneal ectasia. As we saw with this particular young girl, 26-year-old girl, that she was fit for refractive surgery on Placido-based screening, but as soon as we did a posterior surface analysis, we immediately found out that she already has an existing posterior post-corneal ectasia. So what we need to understand is how ectasia comes about. There are two components of ectasia. One is thinning, number two is ectasia. Ectasia, anterior and posterior. There are two types of ectasia that we need to understand. Now let's speculate with a couple of schematic diagrams. Please understand and follow me, and stop me if you require me to spend more time on a particular slide. Now this is the cornea. This you see the posterior surface, you see the anterior surface. Now I'm giving you a hypothetical situation over here where we have only flattened the anterior corneal surface, right? Which is like what we do in a myopic LASIK correction. What it has done, it has produced thinning, but there's no ectasia. So it doesn't fit into the criteria of an ectatic corneal disorder. Now what I have done is I have made a bulge on the anterior surface, whereas the posterior surface remains normal, like in a case of disciform keratitis, stromal corneal edema. But you have an ectatic cornea, but there is no thinning. So one of the two components is missing over here. Secondly, if I go to the third situation, like in Booth-Thalmos, where both the anterior and the posterior surfaces move forward and equally forward. So here we have ectasia on both sides, but we do not have any thinning. Hence, it doesn't fit into the criteria. Now, this is a very interesting slide. We have an ectasia on the posterior surface, and there is an associated thinning. Yes, it does fit into the criteria of corneal ectasia, but this is subclinical keratoconus or posterior corneal ectasia that we find. Now, The fifth possible situation that I can show you is both the anterior and the posterior surface is moving anteriorly or forward, but with a specific rider that the posterior corneal ectasia has to be more than the anterior corneal ectasia, thereby inducing the thinning. So, the essence of diagnosing a case of ectasia would be if only the posterior surface moves forward, or if both the surfaces move forward, the posterior surface has to be more ectatic than the anterior surface, and hence it fits into the criteria of corneal ectasia. What I'm going forward to discuss more is the Scheimpflug imaging. It gives you a wide variety of formats of maps. I'm not going to go into that. It is actually an excellent tool. All the values are available with an instant diagnosis. It's color flagged, that is normal values are white, suspicious borderline values are yellow, and abnormal values are given in red. You can see this map. It gives you the keratometric indices very clearly. It gives you the corneal thickness in the center as well as the thinnest point that you can see. It gives you the antechamber depth. And there is no need to memorize or refer to notes. It is everything available on the map itself when you're working on the system. This is the Bellin-Ambrosio enhanced ectasia, where you can see the anterior surface best float and the posterior surface float of placed side by side. I'm not going into the details of this because it will take a large amount of time. And you can see evidently over here that the posterior surface ectasia is much more than the anterior surface ectasia. And this particular map also has D values which predictive indices of changes in the anterior surface, posterior surface, pachymetric progression, thinnest point pachymetry, and displacement of the thinnest point from the center. I will avoid going into this best sphere concept. It also gives you maps pertaining to normal corneal thickness profile. So what I mean by that is even if a cornea is 420 or 430, it doesn't have to be an ectatic disorder. These maps are a very good guide and give you the normative scale within which the curve should lie. Now, for example, this is the case with a corneal thickness of 447 microns, but if you do the BAD display or the Bellin-Ambrosio display too, you don't find any ectasia, and you find both the thickness profile graphs within the normative ranges. So this is a case of a genuine thin cornea, but absolutely without any ectasia. We get a hang of all the corneal indices that you can think of, ISV, IVA, KI, and each one of them are descriptive with their values. You don't need to memorize them. All you need to do is go and keep your cursor of the mouse on the value, and it will immediately tell you what that value means and what are the normative ranges. And obviously, they'll be color-coded, as I just told you. That will be white for normal, yellow for borderline, and red for abnormal. In a case of post-LASIK ectasia, what I need to emphasize and highlight is it's most important not to look at the anterior surface analysis. Because we have already altered it with our laser vision correction, what is most important to look for is the posterior surface analysis. Either we compare it pre and post-operatively, if we have the access to the pre-op maps, or else we go and do the Bellin-Ambrosio display, which analyzes the posterior corneal surface. Ignore whatever values they give you on that chart for the anterior surface analysis, because that has been altered by us iatrogenically, and the only surface which is not touched by us was the posterior surface, and if it shows an ectatic characteristic, that is the best way to pick up these cases. One of the most specific and important tools two indices that we use today are the progression index and the artmax. Progression index below 1.2 is suggestive of corneal ectasia, and artmax of between 325 and 350 is diagnostic of keratoconus, and any patient having a artmax value of less than 350 should not be undertaken for LASIK, and it's been shown by various studies that it is nearly 100% sensitive and specific. There are various other indices also available, which I'm not going to go through. Thank you very much.